and Sebastian and his team will be presenting today. So welcome, Sebastian. Thank you.
Welcome. Good morning for colleagues from the USA. Good afternoon for Europe and Africa, and good evening for Australia and Asia, I hope. The great honor to be a speaker during that webinar just before Christmas time. It's our tradition to lead this presentation just before in December, just before Christmas. And today we would like to present our last experience regarding cardiotoxicity of anti-angiogenic drugs. I'm Sebastian Szmit. I worked in Poland, in Warsaw, and in Otwock. I'm working in the Center of Postgraduate Medical Education, and I would like to introduce my younger colleague, specialist of oncology, Michał Wilk, from my center, European Health Center, and Michał is PhD candidate and will lead this presentation at the beginning. Please, Michał, continue.
Thank you, Professor, for the introduction, for introducing me. My name is Michał Wilk, and I'm a medical oncologist. I work in the Department of Oncology. And for today, I prepared a case of cardiac dysfunction in a patient treated with cabozantinib. And I'd like to go quickly through a literature review about what we really know about cardiotoxicity of VEGF inhibitors. Before we start, I'd like to encourage and invite you to follow us on Twitter and Facebook, where we post information about what is going on in cardio-oncology in Poland. As a part of introduction, I would like to remind the person of Professor Folkman, who is the father of modern theory of angiogenesis. In his early 70s, he drew this diagram, and his theory was based on the thoughts that tumor cells require blood supply and perfusion in order to grow and to metastasize. Professor Folkman thought about TAF factor, which was called tumor angiogenesis factor. And after almost 50 years later, this diagram looks like this. And in the process of angiogenesis, hundreds of factors are involved. However, what we currently think is that the most important factor is VEGF-A, so vascular endothelial growth factor A, and the interaction between the ligand and its receptors, VEGFR1 and 2, are responsible for vasculogenesis, angiogenesis, and determine vascular permeability. Here is the list of the most common anti-VEGF therapies that are used in modern oncology. There are both monoclonal antibodies, for example, bevacizumab, which is a monoclonal antibody against VEGF-A, and we have also multi-tyrosine kinase inhibitors like sunitinib, sorafenib. The hero, or the villain, as we can discuss, for today is cabozantinib, because our patient suffered cardiotoxicity during cabozantinib treatment. So without any further hesitation, I'd like to share with you a story of our patient, a 55-year-old female, who at the end of 2018, the patient was diagnosed with clear cell renal cell carcinoma. The patient didn't have any cardiovascular diseases in the past. The patient had a medical history of goiter. The patient did not take any medications, and she was smoking for 20+ years. In Poland and in Europe, we do not have any adjuvant treatment for patients after radical nephrectomies. So the patient was on surveillance and performed her first CT scan in June 2019. And unfortunately for the patient, as it's marked in the red circle, we can see a metastatic lesion in the 6th segment of the liver. The patient also developed several metastases to the bones, as you can see on the left, to the thoracic column vertebrae, and on the right side to the skull. So here is the timeline where I'd like to show the ongoing history of our patients. So as I said, in June, the disease was diagnosed metastatic. In Poland, we have two options for the first line treatment patients with clear cell histology of renal cell carcinoma, and it's both sunitinib and pazopanib. These two TKIs are non-inferior in terms of progression-free survival and overall survival. However, pazopanib is said to be slightly more efficient in terms of quality of life. So the patient started her treatment with standard dose of pazopanib. However, 1 month later, she developed hypothyroidism and hypertension. Those very common complications of TKIs. Unfortunately, 3 months after starting pazopanib, we diagnosed progressive disease. As you can see, the CT scan, I don't know if you see my here was the first metastatic lesion, and right away, very close to the first one, second lesion appeared. So that is why we needed to stop pazopanib treatment, and we needed to think about second line. Here is the summary of evaluation before starting a new line of the treatment. The patient had the performance status 1, so the symptoms of the disease did not interfere with her daily activity. She had well-controlled hypertension. Her ECG was without abnormalities, and her laboratory tests were also normal. So in this time in Poland, we have also several options for patients for treatment of the second line. However, there are two main players. It's nivolumab, which is immune checkpoint inhibitor, and we have cabozantinib, which is a new TKI. In our patient, we had a rapidly progressing disease, and we have multiple bone metastasis. So such profile of the patient is probably better to start cabozantinib because it acts more rapidly than immunotherapy, which requires time to start acting. So the patient started cabozantinib with a standard dose, and in the first CT scan, she had a partial response. As you can see, those metastatic lesions in the liver are just much smaller than at the initiation of cabozantinib therapy. Concurrently, the patient suffered from mucositis in the grade 2, which is a complication that is connected with pain, but it did not interfere with her oral food intake. But those symptoms were unacceptable for the patient, so we decided to reduce the dose of cabozantinib. And everything went fine. In March 2020, the patient had another CT scan, which showed us a stable disease. However, in May, something happened. The patient suffers from dyspnea, fatigue. She saw her GP, and he performed ECG, which revealed left bundle branch block. And the patient was referred to our clinic. We performed transthoracic echocardiography, and which revealed ejection fraction of 25%. We made several decisions. We stopped cabozantinib because we thought that probably it's due to this left ventricle systolic dysfunction is caused by cabozantinib. We also introduced some standard treatment for heart failure. We also referred the patients to local hemodynamics, and coronography was performed, and it did not reveal any hemodynamically significant changes in her coronary arteries. So after stopping cabozantinib, we gave the patient 3 months of a period without the treatment. It's the maximum time that we can give a patient in Poland, because cabozantinib is in the reimbursement program, which has this time limit between 2 doses. So we needed to make a decision after 3 months whether we reintroduce cabozantinib or we just permanently stop it. We performed next cardiac evaluation after 3 months, after 1 month after diagnosis of lower ejection fraction, and it revealed slightly higher ejection fraction of 30%. We maintained the cardiac treatment, and the decision that we made was to continue the treatment with cabozantinib. In the meantime, the patient performed a CT scan, which also revealed another stable disease. So we just reduced the dose of cabozantinib to 20 milligrams a day, and on this lower dose, the patient had next cardiac evaluation in September 2020, and her ejection fraction was again lower, around 20 to 25%. I need to say that this echocardiography examinations were performed by the same echocardiographist. So with this lower ejection fraction, again, we just meet with in the cardio-oncology team, and we were trying to find out what is the best solution for our patient. We had several talks with the patient about the possible results of the treatment. And as in Poland, there are no other lines reimbursed in renal cell carcinoma, the patient just made a decision to continue cabozantinib despite this lower ejection fraction. Again, in September, the patient had another stable disease, so we were very, very happy that cabozantinib therapy, which was quite risky, is satisfactory for the patient, and it has oncological benefits. So currently, we continue the cabozantinib therapy at the lowest dose possible. We do not observe any performance status deterioration. The symptoms of heart failure are just at the same level as they were before. And in a few days, we are having next echo evaluation and cardiac and a CT scan evaluation. So to sum up this case, we have a patient whose current progression-free survival at cabozantinib therapy is 12 months, and the patient is taking this drug for more than 5 months while she has deterioration of ejection fraction. So this is for the case that I would like to discuss in a few minutes. And now I'd like to go quickly through the literature review of what we really know about cardiotoxicity caused by angiogenesis inhibitors. Here is the hero of our presentation, cabozantinib. As I said, it's a multi-kinase inhibitor, and it's currently approved in 3 cancers: in kidney cancer, hepatocellular cancer, and medullary thyroid cancer. Here is the summary of complications that angiogenesis inhibitors can induce, and our patient experienced at first, our patient experienced hypertension, and as you can see, it's one of the most specific, the most common complication of such drugs during treatment. And here is the incidence of many TKIs and bevacizumab. As you can see, that the highest risk of hypertension is during ceduranib treatment, and quite low with sunitinib. Here is the review and meta-analysis of studies that evaluated cabozantinib. And what we can see is that all the relative risk of all-grade hypertension of cabozantinib is 5.48, and as well as there is a high risk of high-grade hypertension. The authors of this systematic review and meta-analysis also conclude that the risk of high-grade hypertension with cabozantinib is much higher than the risk of sorafenib, sunitinib, vandetanib, and pazopanib, and the risk of all-grade hypertension is lower than with pazopanib or axitinib. So what we can think is that if cabozantinib is going to induce hypertension, it is the chances that it's going to be high-grade hypertension are high. Here is the mechanism of hypertension induced by tyrosine kinase inhibitors. Of course, the key role it plays nitric oxide and endothelin-1, reduced amount of nitric oxide and increased amount of endothelin-1 causes vasoconstriction, which is the key part of hypertension. Hypertension is a very interesting complication of TKIs. Here, I'd like to present you a study that evaluated PFS and OS in patients with renal cell carcinoma, and it compared two populations. It compared one population of patients who were hypertensive during TKI treatment and those patients who were normotensive. And as you can see, there is a statistical significance between those two groups both in terms of progression-free survival and overall survival.
Goedemiddag, gesprek met Valentina Brakoen van het Beschermingscentrum in Groningen.
In this,
ik heb recent een order gedaan.
Oh, sorry. In our case, we had unfortunately we had different view. Our patient started TKI pazopanib, and hypertension was and hypertension complicated this treatment, but still we had very short PFS. We don't have overall survival data yet. Again, our patient also suffered from heart failure. As you can see that the odds ratio differ from the odds ratio that of hypertension. When you see when you perform an in-depth analysis of this review, you can see that only one study with cabozantinib was included in this meta-analysis, and this one study, particular study, was in patients with medullary thyroid cancer. As you can see, in non-patient experienced heart failure. So we need to look for the data about cardiotoxicity of cabozantinib. We won't find any data in the prescription information. However, we have some data from 2018. It's one of the first glance on cardiotoxicity of cabozantinib. And authors of this trial, they enrolled only 22 patients, and they evaluated echocardiogram, evaluated biomarkers at the beginning of cabozantinib therapy and periodically every 3 months. And the authors, what's interesting, that authors found that after 3 months, two patients of 18 that lived at this period of time, they had reduced left ventricle ejection fraction of more than 10%, but none of them had this deterioration under 50%. After 6 months of treatment, one patient had additionally had a reduction of left ventricle ejection fraction, and one was reaching less than 50%. The authors didn't find any correlation between base biomarkers, and they were not predictive for deterioration of left ventricle ejection fraction. So the authors of this study concluded that routine assessment of cardiac function should be avoided in asymptomatic patients who are on the cabozantinib therapy. We have also a very small third phase 1b study of cabozantinib among patients with multiple myeloma, and there was one case of congestive heart failure. However, investigators did not find it relevant to cabozantinib, but they found it relevant to the history of heart failure. And the last, but not the least, it was published in the Canadian Journal of Cardiology. It was a case of reversible cabozantinib-induced cardiomyopathy. The authors presented a case of 70-year-old man with renal cell carcinoma with a history of cardiac diseases, as they are mentioned here on the slide. And a patient started cabozantinib, and after 4 months, he experienced symptoms of heart failure and ejection fraction 39%. The patient continued the treatment, and after 2 months, ejection fraction was even lower at the level of 20%. So the cabozantinib was permanently discontinued, and within 14 weeks, the authors saw that this ejection fraction just was increasing and was almost normal. So that's all from me right now, and I'd like to ask Professor Szmit to make some final comments on this topic, cardiotoxicity induced by angiogenic drugs.
Yeah, Michael, this is Dan Lenahan in St. Louis. Thank you so much for your presentation. It's interesting, the choice of blood pressure agents that you had when you first started that, started the cabozantinib. You had them on nebivolol and amlodipine, if I remember correctly. Is that right?
Yes, that's right, but it was not started by us, but by a GP, but the patient's GP. And it was quite successive, so we did not change this during the treatment.
Yeah, so I mean, if you're anticipating that a patient on anti-VEGF based therapy was going to be hypertensive, you know, those are probably 2 really good choices. Certainly the amlodipine has pretty good evidence that a direct vasodilator is helpful in that setting, but at least in small studies, nebivolol conceptually is a preferred drug because it has nitric oxide promoting elements, which, you know, a VEGF inhibitor will reduce nitric oxide. So at least on a mechanistic level, it's kind of an ideal medication. But you know, despite that, the patient ultimately developed LV dysfunction. I don't know if, Sebastian, if you have some thoughts as to why that happened.
Thank you, Dan. Excellent comment. I would like to make some comments, and one of them is dependent on your comment. I completely agree that this woman could receive other antihypertensive treatment, including, of course, angiotensin system inhibitors, because we know the data about efficacy of the group of antihypertensive treatment, and of course we believe in cardioprotective and nephroprotective activity of these drugs. So if you let me to continue, please Michael, show my next slide, because you could hear the point of view from oncology department. Now I would like to present my opinion from cardiology point of view, or cardio-oncologist point of view. I would like to remind the paper published by Dan Lenahan. Congratulations, Dan. The paper from JACC Cardio-Oncology, the publication from the last year. And Dan reminded us to think about and understand the risk of cardiotoxicity related to tyrosine kinase inhibitors, especially with anti-angiogenic activity. And please next slide. And maybe you remember this special correlation. This is very important for me, that newer drugs in the group of anti-angiogenic inhibitors, newer drugs may be associated with higher risk of arterial hypertension. It is very clear, as you can see in this table, cabozantinib may be associated with 60% of the risk of arterial hypertension, and the same situation for axitinib, lenvatinib, ponatinib. And I can explain this phenomenon by this way, that the newer drugs with higher anti-cancer activity can be associated with higher risk of arterial hypertension, because we remember the data about correlation, positive correlation between anti-cancer efficacy of these drugs and the risk of hypertension. Please show, Michael, my next slide. I would like to remind our last data regarding sunitinib, and next please. When we observed the patients with metastatic renal cell carcinoma a few years ago, 8 years ago exactly, we published the data about phenomenon, about the fact that the patients with new iatrogenic arterial hypertension related to sunitinib may experience better outcome related to sunitinib, better, significantly longer progression-free survival, and that was surprise at the time. We could observe better, significantly longer overall survival. And please show my next slide, because from this time we have changed our daily practice, because we didn't think about the reduction of the dose of sunitinib, but we focus on the optimal antihypertensive treatment. And as Dan added the conclusion, I completely agree that we think about angiotensin system inhibitors, because when we use these drugs for the treatment of iatrogenic hypertension related to sunitinib or pazopanib or other drugs from this group, we can observe the additional benefit for our patients, because the patients treated with angiotensin inhibitors may experience longer overall survival and of course longer progression-free survival. So we should remember, of course, about nephroprotective and cardioprotective activity of angiotensin inhibitors, but maybe is the molecular pathways common for renal cell carcinoma and arterial hypertension is this group. This is very important for me and for our group, because we know the data from animal models that the animals with uncontrolled hypertension related to anti-angiogenic drugs may experience unbeneficial outcome, may experience heart failure as response to pressure overload. And next slide, please. We can't observe the same, I believe, in patients, because when we have a patient with uncontrolled hypertension, with afterload stress, we can expect the higher risk of heart failure development. And in this situation, the most important question for me is the risk is associated only with the type of tyrosine kinase inhibitor, or this is the dose-dependent effect. because we remember that the risk of arterial hypertension may be related to different tyrosine kinase inhibitor with different risk, but in my opinion we should remember about the risk about dose dependent effect. And please continue, Michael. Please show my next slide. From the data from the position paper of European Society of Cardiology, we can notice that the highest risk of heart failure may be associated with sunitinib, but the lowest risk may be observed in patients treated with sorafenib. So the same situation for the risk of arterial hypertension. So maybe we observe the strongest correlation between arterial hypertension and heart failure risk. And please show the next slide. Maybe the problem is not understood well because the meta-analysis indicated us that there is no special tyrosine kinase inhibitor especially associated with heart failure development. So when we analyze the whole group, we can conclude that the risk of heart failure related to anti-angiogenic drugs is not significant. But please show my next slide, Michael. My practical question is how to use VEGF inhibitors in patients with new recognized heart failure, like in our patient we observe, and how we should treat patients with pre-existing heart failure recognized before anti-cancer treatment. And this is my opinion. Please, Michael, show my next slide. 10 years ago, more than 10 years ago, I published my own experience regarding very young women treated with sunitinib due to metastatic renal cell carcinoma. At that time in Poland, we could use only sunitinib or sorafenib. And when I observed the heart failure with significant decrease of ejection fraction, in this very young woman, I could make two decisions: stop treatment with sunitinib and use sorafenib, or as you can see, I decided to reduce the dose of sunitinib, and of course, additionally, I use the optimal treatment for heart failure. And in this way, I continue the treatment, the effective treatment with sunitinib, and of course I continue the treatment due to heart failure, including angiotensin system inhibitors. And after 6 months, I observed the good oncological prognosis because we confirmed the stable disease by computer tomography, and we observed significant increase in ejection fraction. So this woman was without symptom typical for heart failure. The quality of life was quite good, and we could continue the treatment with sunitinib, but in reduced dose. We use 25 milligrams per day instead of full dose 50 milligrams. And this is my opinion. This is one of decision that we can reduce the dose of sunitinib. And the next solution, my experience with sorafenib. Please show my next slide. A few years ago, when we could use in Poland only sunitinib or sorafenib in metastatic renal cell carcinoma, in patients with the history of coronary artery disease or mild heart failure, asymptomatic cardiac dysfunction, I decided to use sorafenib because the risk of arterial hypertension was significantly lower, and the risk of heart failure was insignificant too. And as you can see, the same correlation, patients with new iatrogenic hypertension could experience the better survival, but the prognosis of patients with history of coronary artery disease or cardiac dysfunction had the same prognosis, the same survival in comparison to patients without cardiovascular diseases in past history. That was very important for my daily practice. And please, Michael, show my next slide. So I like the data, the experience published by Manuela Schmidinger from Austria. Manuela Schmidinger is very well-known oncologist in Europe. Her husband is a cardiologist, so the same situation like in my family. I'm cardiologist and my wife is oncologist. And Manuela, together with her husband, showed us that the prognosis of patients treated with sorafenib or sunitinib due to metastatic cancer, renal cell carcinoma, the patients with cardiovascular events may have the same outcome in comparison to patients without cardiovascular complications. So very, very good prognosis for cardio-oncology for our daily practice. We can very effectively treat, we can use very effective treatment for our patients with cardiovascular complications related to anti-angiogenic drugs. And my last slide, please show Michael. I think that we need cardio-oncology care team. We need to continue our common activity. We usually work together. I can make the significant decision together with Michael, my younger colleagues, and I think it is the best way for the better prognosis of our patients, especially the patients treated with anti-angiogenic inhibitors. And I would like to thank you for your attention, and I would like to know your comments. Thank you.
Thanks, Sebastian. I think, how would you match the publication you had in 2012 with the one that you showed from a few years later, where the one that you published originally showed that people that were hypertensive had a better overall survival, and then later on you showed a slide where treatment with renin-angiotensin system inhibitors was associated with a better overall survival. So one possible question is that in the patients that developed hypertension in your study, did you treat them with an ACE inhibitor or a RAS inhibitor? And was that part of the reason why they had a better overall survival?
Yes, good comment. I can agree, because we use in all patients angiotensin system inhibitors, and maybe in this way we could observe the better survival. It's possible.
Yeah, I think that one view of those types of reports, that people who are hypertensive have a better overall survival. I mean, from an oncology point of view, you say, okay, great, my cancer drug is actually working. And so that, it's raising that person's blood pressure. So that's a good thing. The downside is that we know that treatment of hypertension, especially severe hypertension, is going to have a big impact on a cardiovascular outcome. So the ideal combination there would be, yes, a patient develops hypertension because they're on an effective cancer treatment, but we, the cardiology side of the house, do a better job of controlling the blood pressure with preferred agents, and that combination will lead to the best outcome from a cancer point of view, because the cancer drug is doing what it's supposed to do, and then a better outcome from a cardiology point of view because we manage the blood pressure effectively. So I don't know what you think about all that.
Thank you for this question and for your comment. We prefer to use combination therapy for arterial hypertension because the main purpose to achieve well control of blood pressure. This is the main purpose. As the first drug, I use angiotensin system inhibitors because I believe in nephroprotective and cardioprotective activity. But usually I use the other two drugs because I remember that 70% of our patients needed to receive 2 or 3 drugs due to arterial hypertension. So we use as the first angiotensin system inhibitors, as the second choice calcium channel blockers, especially amlodipine. I prefer amlodipine in my daily practice. And I like to use as the third drugs beta blockers with vasodilatation activity, for example, nebivolol or carvedilol, because we remember the pathomechanism of arterial hypertension related to anti-angiogenic inhibitors. We observe the increase in remodeling and increase in resistance, increase resistance in the vessel. So we should use the drugs with vasodilatation effect, for example, nebivolol with nitric oxide activity, because there is the decreased level of nitric oxygen in the vessel in patients treated with anti-angiogenic drugs. So I prefer carvedilol or nebivolol as the third drug for arterial hypertension, and in this way I believe that I use these drugs due to cardioprotective effect, because many of my patients are older with coexisting cardiovascular diseases. So we should remember that beta blockers may be very effective with very high benefit in patients with arrhythmias, coronary artery disease, with patients with mild cardiac dysfunction, and this benefit may correlate with oncological better prognosis in our patients. As the last drugs, I think about diuretics, because I'm afraid about abnormalities in electrolytics system. And we should remember that our patients may experience diarrhea and vomiting. And I don't like diuretics. I use diuretics only as the last group of antihypertensive drug. So this is my everyday practice.
Yeah, well, I would agree absolutely on that general order. I would use the same basic combinations. The one other thing that I would add, because it's pretty frequent, at least in my estimation, that patients will be on 3 drugs to control blood pressure, and you may actually get to 4. And whether or not that includes a diuretic is kind of a difficult decision, like you said. Other strategies that I've used that with some success is either nitrates or hydralazine to take just as needed. So if a person has spikes in blood pressure, you can give them instructions to take a hydralazine, and that'll work for a few hours and won't cause a lot of rebound hypertension. And that way you can sort of manage occasional spikes of blood pressure. But I don't know if you've had that same sort of experience.
Yes, completely agree, Dan.
Yeah, so I'll add in that I agree with everything that you guys said, that it's not unusual that I get called that the patient started on one of these drugs and their blood pressure is high, and somebody gave them 2.5 milligrams of amlodipine and think that it's going to solve the problem. So multiple drugs, and I know Dan probably does this too, that before we start, they start, if we're lucky enough to see them, I make sure that they get a blood pressure monitoring device and start measuring their blood pressure before therapy begins. And then at least in the first week, I make people call me in the morning with their blood pressures, and I titrate medications pretty rapidly over the first week or two to achieve normal blood pressures. And it always involves more than one drug.
Yes, I agree. Yeah, please, Dan.
No, if I could make a comment from the oncological point of view, because I wonder what you think about ethics of such management of the patient, because on the first side we have incurable cancer, which requires anti-cancer treatment, which has a complication of heart failure with significant reduction of ejection fraction, and on the other side we have this cardiac disease that if we stop the treatment, we know that the patient will surely die within a couple of months. And if we continue this treatment, we put the patient at risk of high comorbidities and deterioration of cardiac status. So how do you manage these ethical problems in your everyday practice?
Yeah, I think that this is a really tough question. This is the one where both you and Sebastian have to talk and come up with the best plan and all of that. So that's where really the collaboration is critical. But just as an example, in this case, the way you presented it, I would say the starting off medications were really great. They were actually, excellent choices. The only question I would have is that instead of nebivolol in that setting, you may have chosen a RAS inhibitor in combination with amlodipine, and then perhaps that would have prevented the development of LV dysfunction. But then later on, you added lisinopril, and the cardiac function improved somewhat. But I think that, if a person's going to die of metastatic disease and you have a cancer drug that's working, you need to figure out ways in which you can optimally manage their cardiac problem to allow them to continue therapy. So in your case, I would say when the LV function started to go down, were there ways that you could have improved that therapy? And so you did one thing by adding the lisinopril, but then also I would have said, are there other ways that we could have improved that therapy? And as Sebastian mentioned, maybe switching to carvedilol at that point would have been a good choice. And, honestly, depending on what you thought the prognosis was, you could even consider doing something like, biventricular pacing if the left bundle and the LVEF remain severely depressed. So, I think these are all considerations. They're difficult decisions.
Sebastian, can I come in here? It's Trishan Singh.
Medium progression-free survival in the second line.
Hi, Sebastian.
What I was trying to
Okay, maybe Trishan first, and then we can hear the comment from Michael. Okay, please, Trishan.
Okay.
Thank you, Sebastian. Would you, when you found the ejection fraction of 25% with not much improvement with your ACE inhibitors and beta blockers, would you consider at this time sacubitril/valsartan combination? I know there's not much evidence in the cardio-oncology scene, but is it something you can consider? Entresto, we call it Entresto here.
Entresto in Poland too. Yes, very expensive drugs without financial support for our government system. So the patient will buy these drugs. So this is first problem. We haven't considered these drugs because we haven't own data, haven't all experience about the efficacy of these drugs in cardio-oncology. But I believe that it can be a good option. But in Poland, the barrier is related to the price of these drugs, very expensive for our patients.
Thank you.
Do you have experience with Entresto in cardio-oncology?
In South Africa, same problem. It's a cost, and yes. It's a huge problem with the funders when you have to motivate to use something off-label where you don't have the data. So it's, I think, a similar problem that you're going to have, or perhaps even North America. I don't think it's going to be very different.
Yeah, so Trishan, just as a point of experience, I mean, we have used it a few times because this person's EF dropped into the 25 range in the United States. You might be able to get Entresto approved. However, in talking with my Mexican colleagues, especially when Entresto first came out, I guess Novartis had a deal with the Mexican government so that they would basically provide Entresto for free. And, something like carvedilol was very expensive. And that's, just the opposite of what happens in the United States, because carvedilol is very cheap. Entresto is very expensive. So anyway, they would use a lot of Entresto in Mexico because it was basically free. And so their experience with it is quite good. So I think that people have used Entresto, and that might be an ideal drug in this setting, but we don't have a lot of experience with it.
Right. Thank you.
I have a question.
Hello.
Do you have doxorubicin? No, not doxorubicin. Doxazocine as an alpha blocker in this situation?
Once again, the name of the drug?
Doxazocine?
Hytrin. Hytrin is a trade name in the United States. Doxazocine, it's an alpha blocker. Yeah, I don't usually use that drug, especially if somebody has heart failure.
This drug is not available in Poland.
Okay.
And the next comment from mine, we decided to continue cabozantinib in reduced dose because we should base on the financial support from our government. And that was the second line of treatment. And in this situation now, we cannot use the next line of treatment because we don't have the financial support from the government for the next line for treatment, for example, with nivolumab or axitinib, etc. So we decided to use the reduced dose of cabozantinib as the only one option for the better prognosis of our patient. Maybe in the next year we have the other plan for anti-cancer treatment in Poland, and maybe the third and fourth lines of treatment will be available through the financial support from our government. But in this woman, it was impossible. And
Yeah,
maybe
you know, you have to operate within your limitations, and you know, I think that the cabozantinib seemed to be working, so you want to stick with it. And I would just sort of look at the cardiac therapy. You know, are there ways that you could improve it? And you know, I would also say this patient probably needs to exercise regularly to try to improve her heart function.
yes, you are right.
There's a couple other questions, it looks like. Daniel, Addison?
Yes, thank you. Thank you, Steve. And again, this was an outstanding and great tag team presentation. You know, I had really, and again from Ohio State, Director of Cardio-Oncology, thank you. My question was really related to blood pressure targets. We know that in the general population, data suggests that lower blood pressure targets are more efficacious. In this patient and in general, and I may have missed that slide, do you have a specific target that you often pursue in this population? I know personally this is a major question. And I think secondly, I would say that we have also had a positive experience with Entresto in cancer and cancer survivors as well, with significant improvements in EF.
You asked me about the targets for antihypertensive treatment.
Yes. So to be more specific, are you when you're saying you're going after blood pressure control, like when you're starting all the medicines and up titrating, is it 140? Is it 130? Is it 120 as far as systolic? What's your target? Is it 150? What are you all doing there in Poland?
Good question, thank you. This is the main problem in our daily practice, because as the European cardiologist and European cardio-oncologist, I should base on the guidelines published especially by the European Society of Cardiology. And till today, ESC haven't published the guidelines dedicated for cardio-oncology patients, the patients with arterial hypertension and cancer disease. In the last guidelines published by European Society of Hypertension, we can find very small chapter about cancer disease and arterial hypertension. We can find only the text about the risk associated with anti-angiogenic drugs and carfilzonib for myeloma. This is very, very small chapter. And so now we don't know the targets, the optimal targets for the patients with cancer disease and arterial hypertension. And in my daily practice, I concentrate for the targets regarding to coexisting diseases. So I use the targets for diabetes mellitus for patients with cancer disease and coexisting diabetes mellitus, the targets for heart failure and coexisting arterial hypertension, and of course cancer disease. So this is my daily practice. I use the guidelines dedicated for other concomitant diseases. And of course the first step is to decrease the blood pressure below 140 for systolic blood pressure and 90 for diastolic blood pressure, because that is European guidelines. I know that our colleagues from the USA have the different targets.
Fantastic.
So can I just add that with 3 or 4 drugs, it's really critical to get standing blood pressures, because you may overshoot and there may be orthostatic hypotension associated with polypharmacy and underlying baroreceptor disease from cancer.
Thank you. That makes perfect sense. I think even in our populations, we face some of the same things. We've had some interesting observations with ibrutinib and a number of other drugs, and this is a very fruitful discussion.
Super. Thank you very much. Thank you, Michael and Sebastian. We're so happy to hear from you in Poland, and you know, really fantastic presentation, and we appreciate the strong cardio-oncology collaboration that you guys have. That's really wonderful.
Thank you, Dan, for
we have our last conference next week of the year 2020, and then I'm sure everybody will be happy to say goodbye to 2020. So
Thank you all so much.
Excellent, Sebastian.
Thank you.
And Mike.
Bye for now.
that's it.
Thank you.
Thank you very much.
Bye, Sebastian.
Bye-bye. Thank you.